Yes, we are good to go.
So good morning, everyone. This is George Papachristou from Pittsburgh. It's time to start our next webinar. Today, I will have my team, specifically Dr. Amir Google, who is my research scholar and has done an incredible work up to now, as well as Greg Owens, my research coordinator, that has placed a significant amount of work with our IRB, so as everything will be ready and cleared by IRB for today. And I would like to thank them both for their great work up to now. So today is a very important webinar. Today we're going to focus on all the practical details on how to use REDCap and how to enroll patients and record data. The first phase of the study, as we have already discussed before, the first phase of APPRENTICE, the acute pancreatitis patients registry to examine novel therapies in clinical experience, will be a pilot phase. Just out of simplicity, the centers that have already submitted and got approval for from PIT IRB, that they submitted the IRB forms, letters, as well as the DUAs, will be starting from tomorrow. From what I understand, there are 6 centers from the US. At this point, we elected to exclude international centers because the IRB approval will take a little bit longer through PIT. You have to understand that IRB regulations are very strict, and it takes longer time with international centers. So today's webinar is extremely important. We are all very extremely excited. A lot of hard work have been placed by our team, but also all of you, to improve as much as possible our questionnaires and keep up the momentum of the study. And now the time has come. Starting tomorrow, we will have all to place our best effort to identify acute pancreatitis patients, enroll them, and prospectively record the data, and our attempt should focus to answer all possible questions. Amir will take over and will give you all the details in respect to REDCap and how to do that. Each center will have IDs to be able to access REDCap, and actually there could be several different IDs per center, or passwords if you wish, so several different investigators could enroll data. It is extremely important, and we would, the next few weeks, be contacting you and asking for your input. Were there any questions that they were difficult to be answered? Were there any of the way that the questions and the answers have been created? Is this something that does not make sense, or it's technically difficult, or it's inconvenient? And our goal is to do all the small details and changes needed before we go to the full phase, hopefully early in 2016. Actually, our goal is January 1st, 2016, Apprentice to be open, not just for the centers in the US, but throughout the world. So it's extremely important. This meeting and webinar will be also recorded, correct, Amir? So for those of you that you could not attend it, please, the next few days, we will have the video available to you, so as you will get all the information needed. I would like again thank Amir and Google and Greg Owens for their great work and support, as well as all these 6 centers from the US that Amir will give you the details in a few minutes, that have shown extremely high level of commitment and efficiency, so as to be ready to enrolling patients starting tomorrow. Amir, at this point I will handle the the rest of the webinar for the technical details to Amir, but I will be available to also provide comments throughout the webinar. Amir, your turn.
Thank you, Dr. Papacristo. It is my pleasure today to host this webinar. It's a very important webinar, and I'm highly honored to conduct this webinar for October Apprentice webinar. I would also like to echo Dr. Papacristo's welcome to all attendees and all centers in this webinar, and take this opportunity to appreciate them for their hard work. And in the last few months, I know that they spend a lots of time in approving their IRB approval letter and data use agreement for. And also thank you, my dear friend, Mr. Greg Owens, who is today with me, and he spent many hours in our regulatory option parts and IRB and data use parts. Okay. Today, I'm going to talk about the pilot phase, the goals and timings, and then we go quickly through how to create a RedCap account. Then we talk about how to enter data in RedCap, and in this way, I'm gonna present an imaginary case through the actual RedCap webpage and discuss about it. And finally, I will talk a little bit about tips on exporting the data from the RedCap. So what is the pilot phase? Apparently, the goal of this phase is to test all variables. This study is a very big registry, and it's very important that all the data be clean and consistent among all centers. That's why it is really important to have all the research coordinators and investigators comments, feedbacks, and suggestions on each question. And I will talk a little bit more about how you can add your comments, edits on the questions. And at the same time, it is important if there is any inconsistency among centers on certain variables to address that. After a few weeks of this phase, we can just meet again and go through the charts and talk about why, for example, I don't know, for example, phyloid questions are not consistent between few centers. This phase is going to run for 3 months. I think it's a very reasonable time to test all the variables and address all the issues. At the same time, I believe it's a very good time for those centers who are under process of IRB approval to join the apprentice for the main and production phase. Just note that the data and the record that is collected in this phase will be included in the main database, and it's not just practicing, and you can save your time and efforts in terms of adding this data to the main production phase. In terms of our collaborative centers, in this phase, as Dr. Papacristo mentioned, we host only approved domestic centers. At this point, including University of Pittsburgh, we have 7 centers, which are Johns Hopkins, Medical University of South Carolina, Stanford, University of Nebraska, University of Indiana, University of Tennessee, and University of Pittsburgh as a coordinating center. Just to update you, up to today, we have 11 approved international centers, which provided us with IRB approval letter and data use agreements. So because of some IRB reasons, we decided not to include them in pilot phase and just run the pilot phase with our domestic centers. And in total, we have 39 registered centers, and 21 centers are under process of IRB approval and data use agreement, and hopefully they can join us for the main phase. I would like to take this time and welcome all attendees. I'm gonna welcome Dr. Park from Stanford, Dr. Shing from University of Nebraska, Dr. Lambias from University of Tennessee, Dr. Isler from University of Indiana, Dr. Depu, Dr. Ipseta, and us. Okay, now let's go how to create RedCap account. Just a few days ago, I've sent an email to all research coordinators and investigators describing how to create a RedCap account. Uh, in that email, I sent you a link which you can see it right now, and I will do it after this webinar again. And after clicking on this link, you will see this page. In this page, it is very simple page. You can just add your basic informations and choose your desired username. But please notice that in the comment section, you have to write the CAPER acute pancreatitis registry wording. In this way, our RedCap administrator will be able to connect you to our apprentice study. Otherwise, it will be hard for them to find you and navigate you to correct study. Just make a quick note that I know that some of the attendees are using their own RedCap for their own studies, but you have to create an account to the University of Pittsburgh RedCap. And the fact that you have your RedCap account does not mean that you don't need to create. You have to still create an account through the University of Pittsburgh RedCap webpage. So I have to say that all participating centers are welcome to add more than one user and create more than one user. And it could be one for research coordinators, one for principal investigator, or any other co-investigators who is going to help in this project for your center. Our only limitation based on our IRB regulation is that the names of users should be included in the site IRB approval protocol. So what are the signs after creating the account in RedCap? You can apparently enter the data. You can export and import data, which I will talk a little bit in more detail in the next slides. You can build report for monitoring your progress through spreadsheets and charts that we will talk in next slides. And just notice that and remember that you can't delete any record after saving the record. You can almost always go change and modify the cases, the variables, the values, but deleting the whole record is not possible through the RedCap. And as we mentioned in the previous webinars, these rights are limited to each center's data and each center's records. The whole pool of the apprentice study is only available and accessible to the publication committee, and each center who's come up, although it's not the goal of this webinar to talk about these points, but each centers can, if they come up with any idea, can contact the publication committee to run the analysis and have the results. But you have full access to your raw data after entering in your site. So let's try a sample imaginary case to understand how RedCap works. Now I'm gonna exit my presentation and go to actual RedCap webpage to show this issue. When you will be granted a username and password after creating an account and after logging into the RedCap, you will see this page. On the left side, you can see the menu part. In the menu part, there is different applications, and on the right side are the general idea, general part of the RedCap dataset. And please make an attention to this link, which is add and edit record. And after clicking on this link, you will see and you will go to this page. In this page, you can see the total number of records that you have already added. And for the sake of uh, practicing, we are gonna add a new record. After adding new records, we go to this page, which is our first instrument to adding data. Just to give you a quick overview over the overall structure of our questionnaire, we have 7 instruments, which means 7 different forms. Each form should be filled and saved and then go to the next form. The first form is designed for inclusion and exclusion criteria. But most importantly, and I think it's the most important point even in this webinar, that before entering the data, you have to assign your record to your centers. And in this upper part of the field, you can see assign record to data access group. And in this drop down box, you can choose your own center. It is highly important step because if you skip and if you forget this part, you will miss the record and you can't have access to export the data. And it will be very difficult for us, although at the beginning we don't have too many cases, but granted after a few months, it will be very difficult to find the case. As it is very important part, I added another question to make sure every center add their own data. After this important part, we go to the inclusion and exclusion criteria. In the inclusion criteria section, we have 3 main inclusion criteria. The first one is serum lipase or amylase more than 3 times of upper limit of normal. The second one is upper abdominal pain, which is characteristic of acute pancreatitis. If the patient meets these 2 criteria, we can potentially enroll the patients, and there is no need to go over the third inclusion criteria. But in cases if the lipase is borderline or the patient is intubated, it's hard to ask about abdominal pain. We can check the imaging and check if the imaging, which is almost always contrast enhanced CT scan, if it is characteristic of pancreatitis. So now I put yes to all of this inclusion. And we have 5 simple exclusion criteria that if the patient meets any of them, if answer to any of these questions is yes, the patient should be excluded. And in this imaginary case, all the answers are no. On the bottom part of each field, you can see a section that you can mark your field as a complete or incomplete. If you mark your field as a complete, does not mean that you can't access the case and change or modify the values. You can still have access and change your values, but it is very good for the sake of management and data monitoring to know that if the field is completed or not completed. And then you have 3 buttons for saving the data. For the first one, if you click on it, you can save it and exit the data entry. For the second one, you can save and be on the same page. And for the third one, you can save and go to the next field. Please notice that RedCap does not have option for auto saving, and you have to save it. And if you forget to save it and sign out it, you will lose your data. Now, in this case, I'm gonna show you next field. So I click on save and go to the next form. And before going to the next form, I would like to tell you that the goal of this webinar is to have your inputs and your feedbacks. And anytime that you have any questions, please write on a yellow hand sign on the right side of your screen. And I will be more than happy to have your questions, your ideas, your suggestion on each field or questions. So I check and I did not find any questions. Okay. Uh, So in the second field, which is demographics, you can see these questions. First, I would like to tell you that every each variable it could be either required or not required. And required means you can't save the data before filling that specific variable. And those variables which are required are highlighted by the red line behind the title of variable. For example, in this field, the patient initials is a required one, the age is required, the gender is required, and the race is required as well. So let me fill it just as a sample one. And now I would like to go to the second point, which is which questions should be asked through the direct interview and which questions uh, should be collected through the patient charts. Uh, we spent lots of time, and after few discussions, we decided that some question and variables uh, should be directly asked the patient, and we put those variables in braces. For example, in this field, you can see that the weight should be asked directly from the patient. The date and time of the pain onset should be asked through the direct interview by the research coordinator from the patient and not just go through the patient charts. But the age, or if the patient is transferred or not transferred, is options that could be addressed just through the via the patient medical charts. And the other point that I would like to highlight in this section is branching options. You know, RedCap is a very smart program that gives us the opportunity and this functionality for branching. Branching means based on your response, you can see or not see some questions. For example, if I answer to the question of if the patient is transferred or not, if I say yes, another question pops up which asks about the date. And if I answer no, I will not see this question anymore. And this is very important point because it saves lots of time in that data entry. And in this part, I would like to talk about the validation, which is very important. As I'm 100% sure that all of you are well aware that one of the most important points in data registry is to have a very clean and consistent valid values among all centers. So on those cases which you have to enter it manually, you have to follow the exact consistent rules to be able to enter the data in RedCap. For example, in this question, which is date and time of pain onset, I'm gonna add today's date, which is 10, and the time like 10:30. This format is exactly consistent with our format, which is on the right side of the variable. But if, for example, I write it as a 10 a.m., you will see that there is an alert, which gives us the information that you can do this, and I have to correct it. Alternatively, the way that I myself like it is to click on the calendar, right to the box, and choose the time and date from this calendar. So let me fill out this form together and then go to the next form. We can choose and wait, for example. And at this point, again, if anybody have any questions, please feel free to ask me any questions. And Dr. Papakristo and Mr. Greg Owens also can answer your questions. Um, I don't see any question at this point, so we can continue. And then we go to the acute pancreatitis etiology. At this point, I'm gonna to tell you that we have few types of multiple choice question in the RedCap. First one are radio button. In radio button questions, you can choose only one answer. And we will see in the next field that there is another type of multiple choice question that we call it checkbox, that you can choose more than one. For example, in questions about fluids, the patient can be treated with both normal saline and ringer. So that question is designed as checkbox that you can choose more than one option. In the etiology question, I chose gallstone and no. Just quickly go through the questions and then we go to the next four. At this point, if you find any problem on any variable, please let me know to address you. These are information on past medical history, which is all are not in braces, which means that you can collect this data from the patient medical charts. And then we will gonna ask a few questions about smoking. Again, you can see if you choose the active smoking, you will ask about the uh, how many years and how many cigarettes. I see that Dr. Singh has a questions. Dr. Singh asks, in the inclusion criteria, any cutoff for duration of pain before transfer? Well, in to the best of my understanding, this is a prospective study, but we don't have any cutoff in terms of day. Uh, for example, if the patient transferred after 7 days, as far as the data is available and we can address and find the data, we can enter the data and include the patients. The only limitation is among those patients who are transferred and the admission information are not available. Dr. Papakrista, do you have any other inputs on Dr. Shin question?
Not really.
Okay, thank you, Dr. Papakrista. Thank you, Dr. Shin, for your important question. Uh, then with the alcohol, and then we ask few questions about family history, about acute pancreatitis, family history of chronic and cystic fibrosis. Again, I mark it as a complete and go to the next four. The third field in the apprentice red cap is dedicated to the laboratory values and pain scores. And I would like to talk a little bit about the timing of vital sign that we have to record it, because it's very important in terms of calculating our predictive scores, and we have to uh, pay a particular attention on the timing. For those values which is under the bar of an admission, we have to pick and record those values which related to the initial admission of the patient. As Dr. Singh very importantly asked us, some of the patients are transferred, and we don't want the information at the time of transfer. We want information at the time of admission to the initial hospitals. And we have to record the vitals and pain and the clinical information on admission rather than at the time of transfer. For the next part, which is day 1, day 2, and day 3, and day 7, we go for the highest recording uh, within 12 hours of day 1. For example, for the day 1, we go for the temperature at 24 hours. We pick the highest temperature recording from 12 to 24 hours from admission. And
I'm
you can.
sorry, Amir. So ideally, we would like the measurement to be done at the end of day one, meaning to be recorded at the end of day one, meaning close to 24 hours, and we're going back 12 hours, and we're picking the highest value. For day two, again, the recording should be done close to 48 hours, and we look back 12 hours, between 36 and 48 hours, and we pick the highest value. Now, for lab works, we're going to go through that, but I just want to mention that, of course, we don't have that frequent measurement, so we're going to go with the labs of the morning of day one, day two, etc. Okay, Amir, you can go on.
Thank you. And Mr. Owens asked a very important questions that is the pain time based on the 24-hour clock? Yes, I was planning to go through the pain. That pain is a little bit different from the other labs. That for the pain we go through within 24 hours, which is a little bit confusing, but I'm gonna just to say it again that for the labs, as Dr. Papacristo mentioned, we go for the one which is closest to 24 hours and then go back 12 hours, pick the highest one. But for the pain at 24 hours, we peak and record the pain which is highest. Okay, then we have.
Amir, I'm sorry. I'm sorry to interrupt you.
Mhm.
If you look at our what we're requesting, we actually go with the highest pay in the last 12 hours. So let us clarify that. For the lab work, usually you only have labs in the morning. So that will be your values. But look at pain. We're saying in our questionnaire between 12 to 24 hours for day one. So it's not the whole day. So at the end of day one, at the end of day two, at the end of day three, for all the vitals, including pain, we're going back 12 hours and we're picking the higher value, the highest value. So we have to classify. Amir, just stay on one area so that the attendees can focus on one area. So for temperature, heart rate, respiratory, and pain, for all the vitals, we pick the highest value the last 12 hours. So for day one, more or less, we should record the time at around 24 hours and we go back only 12 hours. So let us clarify that. Pain is not the whole day. It's the highest value to the 12 hours. So all vitals where we have multiple readings should be recorded this way. We're going back 12 hours. Now for blood work, remember, blood work, we probably only have one recording usually a day. So we're going to go with that, correct? Mm-hmm. So within the first 24 hours, the AM value will be the day one value. Within the second 24 hours, the next day AM value will be the lab value for day two. However, for vitals, we go around 24 hours and we look back 12 hours. We'll go around 48 hours and we look back 12 hours and we pick the highest value, okay?
Okay. Thank you for clarification. Thank you. It's really important.
And this is also what is mentioned if you look on the questionnaires. That's what we mentioned, correct? If you keep it stable, you will see for temperature at 48 hours, highest temperature recording between 36 and 48 hours from admission, okay?
Okay, yeah. Thank you, Dr. Papacristo, for your notice and correcting me. And we have the same thing for the next days. And on the bottom part of this field, we go through the Sears criteria. We just upload a simple table for the Sears that I'm aware that almost all of you know it very well. And we have to mention if the patient met positive Sears criteria, which is more than 2 out of these four criteria. And if it's yes, uh, again with branching, you can see that some new questions pop up. And at the end, we ask about the triglyceride measurement. As there is not a routine measurement in all centers, it is not a required questions. But if it's yes, you have to add the date and the levels of triglyceride measurement as well. And now I'm gonna take this moment and give you one more notice that in every each variable we have a functionality to add comments. And if you look at this button, this yellow button, just near the box, you can click on it and you can write your comment. And this is the goal of this pilot phase. So please, if you if you face any problem, if you had if you have any difficulty understanding any variable, or you think that it is better to write it in another way, please write in the comment section and we can go through it and adding to the questionnaire. And I'm gonna just highlight another point in this section, a final point in this form, that for few variables in this field, we need one decimal. So for example, for the temperature, it is just 37, I have to write 37.0. And if I don't use the decimal, if I don't place the decimal, the red cap gives us an error alert. So, and I just highlighted and I wrote it down like with one decimal on average variable for your ease. So now let's go to the next field. I did not fill it, but which is on the management. For the management, as I mentioned in the previous field, we start with the fluid therapy. And for the fluid therapy, we have checkbox rather than radio buttons. And it means that you can choose more than types of fluid therapy, which is sometimes it is routine in center that the patient start in emergency room with saline and then go to the ringers. And if you click on any of them, some questions pop up which ask about the amount and amount in 6 hours and 24 hours. Now I'm gonna give you a little bit information about
Again, amount of fluids the first 6 hours, including the emergency room, meaning from the moment they reach the hospital for the first 6 hours, including emergency room.
Mhm.
And then the second measurement should be all first 24 hours, including the 6. So let's say the first 6 hours they got 1.5 liters, and then the rest of the day they got 2 more liters. The first reading should be 1.5 liters, and the second should be 1.5 plus 2 equals 3.5 liters, okay? Just to clarify. And again, it will take some time for you guys to get familiar with the questionnaire. Any question that you have, you can always email Amir and myself. And again, for us is also because we just have not enrolled any patients yet. We've just have done dry runs. For us, it's also a work in progress, especially for the fluids and the recording of the vitals. We have to be very, very careful and make sure that we understand what we're doing. Okay, Amir, you can continue.
Dr. Papacristo, Dr. Isler raised the very good questions that I'll read it loudly for you. One challenge for pain data will be in transfer patients. We may not have pain values in the first 72 hours at an outside hospital. Sites may need to be very specific with their record requests from outside hospitals and ensure that we obtain nursing records as well. Do you have institution or parameters for sites to request records from referring centers?
What we usually do, Jeff, first of all, good morning and thank you for joining us this morning. We really appreciate all your interest and effort. With our experience with our ongoing acute pancreatitis study, clearly there is a lot of, it is challenging to correct details on all the data from the outside hospital. What we usually do is we include in our IRB and in our consent form, permission of the patient for us to contact the outside hospital. So what we do is the moment that we coordinator, either Greg or Kim, will contact the outside hospital and will have all the clinical records, including vitals, progress notes, lab work, reports of imaging, sent to us. Granted, is it sure that we're going to be able to extract all the information at this point? No. And you know, these are the challenges with transfer patients. Now, one of the suggestions that we'll have for all of you in the pilot phase is if you have a patient that comes to you far out and you feel far out from his presentation, so it's day 5 or day 6, and you feel that it's very hard to record, you know, the vitals in the first few days, the amount of IV fluids they have received, an accurate sears, so many of the important values. This might be a patient that it might not be worth it of enrolling. Or this might be a subgroup of patients where we will have limited data. What you can do is initially in the pilot phase, try to enroll everyone, I would suggest. See how much from different satellite hospitals, how much information you can gather, and maybe a month down the road when we meet again, we can discuss for each centers these limitations and come up with a solution about it. But clearly, there's no perfect answer into that. Okay, Amir.
Thank you, Dr. Papacristo, for your answer, and thank you, Dr. Isler, for your great question. Now we move forward to the part about narcotics use. Um, Again, it is with branching. If we put yes to this answer and respond yes, a table and few questions will pop up. Um, as we need the consistent data, we decided to report morphine equivalent narcotic doses. And I know that in every each center there is different narcotics which will be used. Even in our center, it's not just morphine. So in order to calculate the morphine equivalent doses, we upload this simple table that gives every each narcotic a brand name and a generic name and the route. And there is a number that we call it equianalgesic. So if we definitely know the total dose of the narcotic use of every each day, and then we can divide it that dose on equianalgesic number of the particular narcotic, and then uh, 10 times more, and this equals the morphine equivalent dose. Now here you can see this formula. It is very easy. For example, in this example, the patient took 60 milligram of oxycodone, and we divided on 20 and subtract 10, and the result is 30. And the morphine equivalent dosage is 30 for this patient. So please take a quick attention to in this uh, table. I know for the first two patients it may be a little bit tricky, but I know it's very easy for all of you. And in terms of the dosage and the duration that we need the dose of narcotics, for the day one question, we need full 24 hours from the admission. And for the day two, we need from 25 to 48 hours, which means if the patient admitted just today, and for the day one dosage, we add all the narcotics which is added together and then calculate the morphine equivalent and write it down here. Then we go and ask few questions about the ICU admission, and if it is yes, they ask about the duration of ICU admission and the mortality in the ICU. Now I'm gonna talk a little bit about the nutrition. This is a little bit tricky, and we spent hours to crystallize questions in a way to cover all scenarios. Uh, in the nutrition section, we decided to record all attempts. For example, if the patient start with attempted oral and then did not tolerate it and go to enteral and then tolerate it for a few days and then again switch it to the oral, we want to record all data. So we provide you for a few questions. The first question is the date and time of initial feeding attempt. Just notice that it is not tolerant, it's just attempt. For example, if the patient is attempted and not tolerated, still we have to record this information in this variable. And then we ask about the route of the initial attempt. And then we ask about if the patient tolerated or not. And then go to the next one. And based on your answer, some questions comes up or disappears. And finally, we ask about oral tolerance. For the next part, if anybody have, I think Dr. Isler has another question that I would appreciate Dr. Papacristo to answer them. What aspects of the subject's data points, such as pain, nausea, and vomiting, will be acceptable to assess through an interview? Pain level and admission at an OSH outside hospital, nausea, vomiting, and admission. Dr. Papacristo, can you answer Dr. Isler question?
So these questions were recently added in an attempt to get some important data for Dr. Beach and Wu's attempt to develop acute pancreatitis clinical index that we could potentially use for future studies. So I think these questions are best answered with interviews. So when the research coordinator goes and sees the patient on day 2, let's say the morning of day 2, they will ask him, the last 12 hours, have you been nauseous at all? Probably the patient might be on Zofran already. So if the patient says yes, I continue to feel nauseous, and last night they gave me a shot for the nausea and I felt better. So I think this patient still has nausea, correct? We completely realize that this questionnaire is intense, and the data on IV fluids, vital signs, as well as nutrition are intense. At this point, I would like to share with you that nutrition, we follow the patients for each attempt of nutrition. So let's say on day 3 they're doing better, and we start oral feeding, and the patient eats, but they cannot tolerate and throw up. So 12 hours later, we say, okay, we're going to switch them to NPO again. This was an attempt of oral nutrition, which actually failed. And we have these questions in each of the attempts. So there is this clear question that you can see it on the screen right now, tolerance of initial feeding attempt. So if they fail oral and then the following day they get an NJ and they start on tube feedings, the first attempt is oral and it failed. The second attempt will be enteral. Again, that's why it's extremely important not just to enroll a patient and go into their chart in 7 days, but this should be a daily involvement with the patient. It is very important that the research coordinator pass by every morning and check on the patient, collect the important information on the last 12 hours as far as the vital signs and symptoms like nausea. Follow carefully how much narcotics they were given the last 24 hours and the IV fluid, so we can follow that, as well as the attempts with nutrition. So it's not just we enroll a patient and then a week later we go into the chart and we try to fill as many information as we can. No, this is a prospective heavily involved study, and what we ask and we realize it's a huge burden, but that's how we're going to get high quality answers, is for the research coordinator on a daily basis record some data that come out of the charts, but some of the questions that can only be answered with personal interviews. Okay, Amir, thank you.
Thank you, Dr. Papacristo, for your informative answer, and Dr. Isler. It's very important to be interactive, and I like this way of. I think it's the only way to achieve the goal of this webinar. And I would like to ask the other attendees to ask their question, and we will be so happy to answer them. Now we move forward to the part for inner intervention. We have three parts of intervention, and we're gonna ask about three parts. The first one is intervention in terms of any debridement uh, or drainage. So in this part, if the patient responded yes, if the research coordinator responded this question yes, the two questions will appear that ask about if it is only drainage, is it drainage or debridements or both, and the way that the mode of intervention in terms of laparotomy, minimally invasive surgery, percutaneous drainage, or endoscopic one. And just I would like to highlight this point that we define early intervention in terms of within 2 weeks. And any intervention after 2 weeks of admission will be categorized as delayed one that we will see in the next form. And we set a different field to make it easier to save this form at this point and then go again to the patient later in the course of the patient hospitalization for the delayed intervention. So I'm gonna move to the next form and talk a little bit about outcomes. In the outcome section, we go to the main outcomes of the patient hospitalization, which we start with organ failure. Based on the revised Atlanta classification, this is a very important point in categorizing patient and defining patient severity. As you can see, this is not radio button question, and this is checkbox, which it means the patient at the same time can develop more than one organ failure, and it could be cardiovascular, respiratory, and renal. And these definitions are based on modified Marshall score that I don't want to say it again. I know that most of you are well familiar with this scoring system, and I just wrote it and mentioned here. So if you have any question in definition for organ failure, please contact us or ask question at this point for me or Dr. Papacristo to answer this. And then we go about the infection. And again, I forgot to mention that if you click and respond to any organ failure as a yes, few questions will pop up and ask about the duration of organ failure. Is it transient? Is it persistent? The total length of organ failure, and so on. Then we move forward, ask few questions about extrapancreatic infection, the possibility of any pneumonia, any urinary tract infection, Clostridium difficile, or any cholangitis. On the next part, we go to the radiologic information. If the patient went through any contrast and has CT scan, and if it's yes, we ask few simple questions about pancreatic necrosis, peripancreatic one, or any infection. I would like to talk about peripancreatic necrosis, that we are well aware that not all radiologists among the country report this entity, and it is a little bit new entity which was um, presented in the revised Atlanta classification. So we mentioned one choice as not recorded in our centers for peripancreatic necrosis. And maybe the most important outcome of our questionnaire is revised Atlanta classification severity. That we hear the simple grade severity boxes, that it's very important to make a very good attention in this question, because it's very important for us to have very clean data in this part. We define severe acute pancreatitis based on revised Atlanta classification as development of persistent organ failure. I mean, based on the Marshall scores that we defined in the first question, If the patient develop any organ failure more than 48 hours, single or multiple, either single or multiple, we can categorize the patient as severe one. For the moderately severe acute pancreatitis, are those patients who develop organ failure but resolve within 48 hours. For example, we have couples of patients who develop increased level of creatinine, but after a day with hydration or anything, they will resume to the normal level. We put those patients in moderately severe group, or any local or systemic complication, which means mostly through the radiology and the imaging CT scan of patient, if there is any necrosis, any wall of necrosis, any fluid collections, and necrosis, which put the patient in the moderate severe group. And
Amir, let me interrupt you for 1 second. I'm sorry. All the centers that were going to be involved in the pilot phase, we are university centers, big centers. I would recommend, rather than just use the report of the radiologist, maybe once every 2 weeks or so, if there are any CTs, sit down with one of the radiologists, one of the abdominal radiologists that you feel that they are much aware of the local complications, the way that they are defined by the revised Atlanta classification, and make sure that these radiologists go through the scan and give you an input as far as if there is necrosis, how much necrosis, if there is peripancreatic necrosis. Because that would be very important. I would not rely on the report, especially if you are a big division. It might be, and that's what we do in our studies, might be reasonable once every few weeks, sit down with the radiologists that you trust, that they're familiar with the revised Atlanta classification, and go through the scans. Thank you, Amir.
thank you, Dr. Papacristo, for your point and for your information. I see that Dr. Lambias have a question. Dr. Lambias, do you want to talk? I unmute you and you can talk at this point.
Arrow on the top.
No questions, sorry.
Okay, thank you, Dr. Lambias. Okay, and we have another classification system, which is determinant-based classification. And now you can see the table to use in this classification. It is a little bit similar to the revised Atlantic classification, beside the point that they added the point of infection, and we have this new category of critical acute pancreatitis. And then we go forward to one of the most important outcomes, which is mortality during hospitalization. And if the response to the mortality is yes, is no, we go and ask about the question about discharge date and the total length of stay. And then finally, we ask two questions about patient satisfaction, which is how the patient is treated and how the patient is managed based on the patient point of view. Now I'm going to go to the next four, which is...
Amir, I'm going to interrupt you. So the patient satisfaction questions should be directly answered by the patients at the time that they're close to their discharge. We are already an hour into the webinar, Amir. So let us try to wrap it up, okay?
Sure. Yeah, we are near to be done. This field is for delayed intervention that I mentioned, that we define delay as more than 2 weeks. It is similar to the questions about intervention in the early one, with just this difference that it is more than 2 weeks. And the final fit is for follow-up. For the follow-up sections...
Sorry, we have to mention here that delayed intervention might take months.
Mm-hmm.
So in the follow-up, when we call the patients 3 months down the road or so, it's important to ask them if they have an intervention as well, correct? or follow up with a chart, because this the tendency nowadays is not to intervene early, but give time to the necroma to mature, and this might take up to 6 months.
Oh, thank you for your point. Uh, so now let's move forward to the last field of our questionnaire, which is for follow-up. In apprentice study, we have just one session follow-up, which should be around 90 days of the admission. And we have a window of like 30 days before and after, because we know that it's a little bit hard to be exactly at this 90 days. So within 60 to 120 days from the discharge, it is okay to call or through the patient visit, office visit, fill the follow-up information. And if you put yes to any of them, you can see the question follow-up, which is quite similar to the previous questions. The final point that I'm gonna to tell you and wrap up this webinar, I know it's Sunday and everybody's a little bit tired, and I don't want to ruin your weekend, is how to export the data. On the right side of the screen, you see the application bar, and you can click on the data export tool. And in this section, you can see you can export data as two formats of all data or advanced option. In the advanced option, you can go and choose each field or even variable and export the data. And the export data could be as an Excel data file or SPSS and other formats of softwares which is used for analysis. Now I'm gonna wrap up this webinar, and thank you everybody for attending and listening to me. Please click on the yellow hand button if you have any question. I will be happy to answer your questions. And that's it. Thank you. Dr. Papakrista, do you have any final comments?
Amir, I would like to thank you for your nice job and involvement. Again, it's a work in progress. There are gonna still be questions that you guys will have to fill, and you might have we might not be sure how exactly to record. That's why we'll be available. Both Amir, myself, and Greg will be more than happy to answer those and improve any deficiencies and any issues with the questionnaire. I understand it's a very detailed questionnaire, but just to give you an idea, just by filling this questionnaire, we'll have so many opportunities for great study for all our studies, for all our collaborations. In a multi-center, multi-continent fashion, will be able to compare the revised Atlanta classification with the determinant-based classification, for example. We might, for the first time, be able to have patient satisfaction, prospectively enrolled questions that we'll be able to record. The use of nutrition throughout the world, different aspects of management and outcomes. So I realize it's a lot of work for the research coordinator, especially in this phase of the study, the first phase that's going to last for a year, where we won't have funding. But I think if we do a great job, we will have a very important backbone that we will be able to base applications for funding in the future, as well as for presenting great papers. So we will be in touch with you. Starting tomorrow, we'll try to enroll our first patient, as all the other 6 centers should, because we're cleared by IRB. And again, we will be contacting via email back and forth, make sure that everything is going well. And again, the understanding is that you guys should follow this patient prospectively on a daily basis, fill in your forms on a daily basis, rather than just enroll a patient and let him or her for a week or 10 days and then try to do everything at the end. This is not exactly a prospective fashion. We really need to capture this data in the prospective fashion, and we do appreciate and realize that this is a lot of work, but this is how quality research can be done. And again, thank you very much for your time. your support and enthusiasm. And again, Amir, thank you very much.
Thank you, Dr. Papa Christo. And if there is any other questions, and if not, thank you very much again, and thank you, my friend Greg Owens. Have a very good weekend, and bye.